Good evening, ladies and gentlemen. It's 5:30, so we'll make a start. Welcome to the Health and Adult Social Care Policy and Scrutiny Committee. It's Wednesday, the 27th of July. We're just waiting on a couple of other councillors to arrive. I suspect they'll be on their way and stuck in traffic. We're not expecting, we haven't received any apologies, so I'm expecting full complement this evening. I'll not go through usual housekeeping because I think everyone that's here is familiar with the process. So does anyone have any declarations of interest other than listed? No, thank you very much. The minutes of the last meeting, which was the 5th of July, they were on the online agenda, but they were missed somehow from the actual printed papers. So you should have a copy to hand. I don't know whether you've had a chance to check them online. Are members content with having had a chance to look through them? Yeah. I just would like to add one thing that's not been mentioned, just to make it clear from that meeting, because it was the meeting where we discussed the dementia strategy. And I did suggest that it's important that with any type of strategy that we have, that there is some kind of reflection against previous strategies, and that's not really referenced in here. I'd like that, making a point of that specifically adding, please. But otherwise, I'll be content with the rest of it. Okay. Right, we don't have anyone registered in public participation today, so we can move straight to the first of the main agenda items, and that's item 4, pages 1 to 10 on the York Place Health and Care Partnership Board. And I'm pleased to say that Councillor Carol Runciman's joined us, the Executive Member for Health, for this item as well. And we've got officers Jamila Hussain and Sharon Stoltz and Steve Tate to help answer questions for the reports this evening. So would you like to introduce Jamila? Jamila, is the mic on? I'm not sure it's working fully. It's very quiet.
Is it on now?
Oh, that's better.
You know, I've been here a year and I still can't use this link, so
Thank you.
that's not very good. Can you hear me now? Shall I start again?
Yes, please,
Okay.
for the
Right.
benefit of the webcast, I think, as much as anything.
Okay, so I
Thank
just
you.
want to start with saying that the work that's gone into this report has also been done in partnership with my colleague Sharon Stolt and Peter Roddick, who work on this agenda with me. The report is in 2 parts. One, it's about the Health and Social Care Alliance Board that has now morphed into the York Place Board, but it's equally to acknowledge the work that partners have done. That we were quite fortunate in York that we did have an alliance already, so we did have health and social care partners together with our community and voluntary sector partners working together, and it made us quite easier to have a York Place Board. I think one of the key outcomes that we've all agreed is that we want to make York one of the healthiest cities in Northern England. But we do have specific areas of inequalities and work that we need to really focus on. We've aligned it with the health and wellbeing strategy and the key elements of starting well, living well, aging well, and dying well. So all the work that we'll do at the Place Board actually is in parallel to what we're doing at the Health and Wellbeing Board. So there's no there's no conflict of delivery between those two, the place board and the health and wellbeing board. And I think the paper just highlights key areas of what's happening in York at the moment. So good
Sorry,
health.
Jermaine, could you move it a little bit closer? Because it's really, the acoustics are not great in here. I don't think.
Can you hear me now?
There's a bit of a whirring noise.
I think
as
it's
well.
because I've got the AC running behind me. Can
Yeah.
you hear me now?
I think we just really have to speak up this evening.
Oh, all right. So can you hear me now?
Thank
Yeah.
you.
So I think what we want to make clear is that good health is not evenly distributed. So in the report, we talk about that York is perceived as a healthy city. However, there isn't good health across all areas of the city. Good health is not usually the best health. So we talk about, you know, life expectancy and people living longer. But what we want is people to live healthier for longer, not just to live on longer. And hence why we've highlighted that good health is not necessarily always the best health. And what we always see, and Sharon sort of explains to me in great depth, that good health in York is not evenly distributed. So we have real good pockets of where we have, you know, good life expectancy, good health, lots of people enjoying exercise, and then we have other areas around where we have high inequalities in access to services, and how we then provide care across social care and health. Can be challenging and difficult, and this is where the York board is really going to concentrate on how do we reduce those inequalities across the patch, and then service delivery in particular. I'm not going to go really through the demographics, but I just wanted to highlight to you about, and I've talked about it before here, about mental health and mental health admissions into mental health units, and the higher suicide rates we have in York. Lower than average income for our children. So I was talking today to some of the social workers around neglect. And are we looking at neglect, or is it really poverty that is causing some children to perceive a neglectful household where it's not? It's actually how do people maintain healthy lifestyles and supporting young people in their own home whilst there is high cost of living. And then the preventable ill health around smoking and people being overweight and weight issues there. But not just to mention about people being obese, we do have a high number of people with eating disorders within York. If you talk to my health colleagues, they will say that that is increasing as we've coming out of COVID. I just want to talk about how the health board came about. I did discuss this last time, that through the development of the ICS, the integrated care system, was agreed that we'd have 6 place boards, and York is one of those place boards. So it's very much come out of the Health and Social Care Act, which came into being in April this year, 2022. And that actually puts health and social care together on a place as well as a regional level. And it's a good opportunity for us to be working in different ways. So in point 8, I have set out the national and local context of why this has come about. I think people will be aware, those who are involved in health and social care will know that the operating guidance came out last December. That is the guidance that the NHS work on to deliver on a 12-year programme. And one of the main things was investing in strengthening the workforce, but that was with health and social care. It was one of the best operating guidance that I've seen for a while, because it was very integrated. It talked about improving access to primary care, but alongside local authorities. It talked about developing an approach to population health, and not forgetting our Director of Public Health. So usually we get operating guidance that's very fixated on the acute trusts and how the acute trusts work. This one, in readiness for the ICS, was talking about those joint workings and how we can move together, and how we can then establish those integrated care boards that take on a whole population approach rather than a single or a multiple condition approach, which is slightly different. Just wanted to talk a bit about the Health and Care Alliance Board, because that was already in place before I joined York, and they've done lots and lots of work around tackling some of the inequalities around learning disabilities was one of their priorities, as well as complex care. So they set sort of almost the foundations for us to build the York Board on. So the York Board will concentrate really on redesign of services locally. How do we do our commissioning arrangements and the general functions of health and social care at a place level. But I do want to make it really quite clear that this is an NHS redesign, not a social care. So the whole structural changes with the ICS, the ICBs, and the Health and Social Care Act was mainly around the health changes moving from CCGs into ICSs. But what it actually gave local authorities was a really good firm setting, more than I've ever seen before, of integrating some of its functions. Hence why you can see on our York Board is chaired by our Chief Officer, Ian Floyd, and the rest of the 5 boards are also chaired by council chief execs, which is highly unusual. We're one of the areas in across the region and almost nationally who have got to a point of a really mixed leadership approach to place delivery as well as regional delivery, and I didn't want to lose that here. So where we are in our current position, we are developing the 10-year health and wellbeing strategy that's well underway. Sharon Stoltz and Peter are leading on that. The ICS are also developing their 5-year strategy, which will interlink with the health and wellbeing board strategy. We have met as a York Place Board now. I think we had the 3rd meeting on Monday, and we're moving towards, so what does it look like around what priorities we should be setting for the board. In particular, we know, and I've brought it here to scrutiny, that we have a high number of hospital admissions. We have a number of delayed discharges for the stay in hospital. Our mental health delivery by population and the inequalities we have across the system around mental health needs also needs tackling. And then we have the issue around children's service delivery. So those are some of the areas that the York Place Board is discussing, but we want to align our key priorities with the Health and Wellbeing Board. As we move forward, underneath the Place Board, we will have some working groups, and I hope to present a paper here at the next scrutiny around what those work streams would look like. This board, I think Sharon and Michelle presented a paper around quality and safety at a York Place level, because people were saying, well, what happens then if everything's gone up regionally? How do we ensure that we maintain a local place delivery? And the work streams we're looking to bring in place are quality and safety, making sure that the services we deliver locally, integrated with our health colleagues, are safe and of good quality. A sustainable integrated workforce. I have talked to committee before that singularly health on its own can't do it. Social care on its own can't do it. And it's about how do we have a sustainable workforce together. Performance management is key. Everything that we commission and redesign is that meeting our performance targets. Financial allocation at a place, and then the governance frameworks, making sure that from a council perspective, we have the right governances in place, and the decision making, health decision making is quite different than a local authority, and it's making sure that we align both together so the decisions are made in a seamless way. So the next steps really are to develop those work streams, really have a key focus on what that finance looks at in place. It's not going to be done in a couple of months. We look at this being phased up until April, where we'll know what our financial allocation from an NHS perspective is at a place level, where we are with social care. We also will need an update on the BCF. As we know, the BCF is a function that we can use to integrate and pool some of our budgets. It works really quite well in York. We have a 2-year MOU, so it runs up until April next year. We're still waiting for further guidance of whether this will be a lever that we can use to pool more of our health and social care monies and have a bit more of a redesign. And the rest is to work on making sure that we have the York Place Board membership correct. We have a multi-organisational membership at the moment, including patient voice, but we will review that membership as we go forward. And like I say, the next steps are is making sure that we've got the right membership, getting the work streams in place so the work can start in earnest, learning from the Health and Care Alliance, but continue that work. And what we've decided is that we haven't got a NHS Place director in place at the moment, but as a board, we are moving forward because we don't want to lose the momentum of the good work that we've already got going. So I'm just going to leave it there. I don't know if my exec member Carol wants to say anything further.
By all means, if either Sharon or the executive member want to add anything, or indeed as we're going along in the conversation and the questions, if you want to assist with any answers, you're welcome to as well. Sharon.
Having the same problem. It's working now. I'm just happy to take questions from members, Chair, as opposed to adding anything to what Jamila has said. I think I just wanted to comment on the fact that it's very difficult to hear with the air conditioning on. I wonder if it'd be possible to switch the air conditioning off. We have good ventilation with the windows and the door open, so I think we'll be perfectly safe if we turned the air conditioning off.
I'm content with that, if everyone else is. Certainly, yes. Yeah, I wouldn't know how to.
I was going to say, does anyone know how to?
That's a disabled channel.
I don't think it's controlled in here.
Ah,
And my experience from another meeting was it went off in about 20 minutes. So
right, okay.
whether
It's
will
possible
stop.
that it might not be controlled in here, apparently, but it's probably on a timer. And, we might just have to live with it and speak loudly. Thank you. Members' questions then, please. Go ahead.
There we go. So, can you hear me okay? Grant. Okay, so looking at page 6, we've got the red flag issues there. Now, first one really, alcohol consumption and alcohol habits obviously flagged as a red flag, and there was some coverage on this yesterday. What's the anticipation of how that's going to be impacted by the pandemic?
So, as the report indicates, and the Joint Strategic Needs Assessment goes into more detail on this, York has a higher than ideal issue around alcohol at the moment. It's important to say this is not related to York being a tourist destination. This is actually based on residents in York and their attendance at hospital, for example, for alcohol-related issues and alcohol-related deaths. So this is focused on people who live in York. We haven't got any firm data on this yet, but anecdotally, we know that drinking levels went up during the pandemic. You just need to listen to people, people's experience to know that. And we know that in York, amongst our residents, it's drinking at home, it's social drinking, it's people not falling about drunk necessarily. It's really about social drinking, getting into the habit of, you know, having alcohol with a meal, alcohol around socializing. And so a lot of the drinking harms that we see are actually often amongst some of our more affluent populations who really aren't necessarily aware that they're drinking at harmful levels. So part of the work that we're wanting to do with alcohol, and we have a campaign due to start shortly across the city, social media campaign, is really encouraging people to think about how much they're drinking, to be more alcohol aware, and really focusing on that prevention element. But also we're working very closely with GP practices. Our health trainers that we have within the council are also focusing on alcohol, because we want to avoid people developing a serious problem around drink and then needing to be referred into our specialist services. We did an alcohol needs assessment quite recently, which showed that we have a gap in those early intervention services. We have the specialist service, but if a GP, for example, doing a routine health assessment on someone, identified that they were drinking at harmful levels, there wasn't a service to refer them into. Whereas there now is, because we've managed to extend our health trainer offer. So we expect our alcohol levels to get higher. That at the moment isn't being reflected in referrals into the specialist service. So we're hoping that this new campaign and service that we've got in place will be able to pick up those individuals and encourage them to change their drinking behaviour. Yes, I mean, hopefully that explains, Councillor Heaton, our approach that we're taking towards this. And then finally, just to add that we've just established a drug and alcohol partnership board for the city, which we've developed in consultation with Councillor Runciman, and I'm the chair of that group that has representation from a number of partners on it. So we're really aiming to take a citywide approach to this, not just looking at what the NHS can do or what the council can do, but looking at a whole council approach. And I'll be very happy to bring updates to this committee on any of that work, if that's something the committee would be interested in.
Thank you, because the figures coming out indicating yesterday that drinking habits that have increased over the pandemic aren't then falling back. So if we're keeping an eye on that, I think that'll be helpful. Right, carry on. Thank you. Talking about partners then, I had some conversations recently with senior GPs out of area, and there's a concern that's quite evident that there's a lack of GP representation within these new integrated systems, whether it's the partnerships, the boards, or even the place levels. What are we doing at this level to make sure we are getting GPs' input and involvement?
Yes, it's a frequent request from GPs, but then when you invite GPs to partnership meetings, they're too busy to attend. So, you know, it's both sides, isn't it? How we're addressing this in York is to go to GPs rather than expecting them to come to our groups. We're very fortunate in York in that we have Nimbus Limited, which is a partnership organisation that all York GP practices are members of. But we also have the primary care networks in York, the clinical leads embedded in the primary care networks. And we also have GP representation on the Health and Wellbeing Board, in the York Health and Care Alliance, and we also have a York Health and Care Collaborative that is actually led by GPs, and they are a standing item on the Health and Wellbeing Board in terms of presenting their reports. So there is good GP engagement in York at all levels, I would say, at a strategic level, but also clinically, there's good partnership working with them. So if we take the example of the health trainers and the alcohol that I mentioned earlier, that work is being developed in partnership with our local GPs. It is a problem in other areas. I think one of the advantages we have in York is our geography is quite compact. We only have about 15 GP practices, I think, across York. So it's much easier for us to be able to proactively engage with them than some large cities, for example, Leeds, that will have many more GP practices. So I don't think that's a complaint, or I hope it wouldn't be a complaint that, you know, you would hear in York. Because we do work with them and see them as, you know, key partners in everything that we do.
Excellent. And I've just got one more. It's on a topic I've sort of raised previously, around mental health. We've got a provider organisation in our place that's split, not obviously outside of our place, but also it's split across ICSs. Two of the largest and more complex ICS in the country. How is it anticipated that those services will be impacted given that necessary spread from that provider?
Yeah, so CHUV is a large organisation that works over a large geographical boundary, and I think there's some benefits in having a large organisation that covers a large boundary, but equally it's about, as I mentioned in the report, about us designing and redesigning services that deliver a place-based level, because when we look at some of our data, the needs of the mental health are very different than in York than they are even in North Yorkshire, a neighbouring authority. But it's all about how do we redesign services that are similar across the patch, but then focus some of that intensity within York. So some of our CAMS, for example, our children and adolescent mental health services, there is a need in York, but that doesn't mean that the delivery across the region can't be similar, but the intensity of sport and the number of practitioners we have in York may be higher than there are in North Yorkshire, similar to adult mental health on a community level. It would probably be the same delivery mechanism, but the concentration of support might be different in different areas. Hence why we're looking at working on a place level to say, well, what our needs are, and we do know what the needs are, and working with CHUV. So I wouldn't say because we have a large provider, a single model can't work across. It's how you then identify that need. And when I talk about inequalities of access to service, that's what we have now, and we can see it now across York. But when we look to a place delivery and work with you to say, what does that redesign look like? It will really help focus the need and services across areas.
Thank you. Councillor Barnes, please. Yes, certainly, yeah.
a very, very big area. Oh, sorry, thank you, Margaret. Big area that it's covering. And I know there have been rumours in the background that they might split it in half, but I honestly don't think they're going to do it in a hurry, despite the fact it's so enormous. So I'm sorry if people missed part of that, but I think we've got a problem with the technology today. Thank you, Margaret.
Thank you. Councillor Barnes.
Thanks, Chair. A couple of questions, if I may. One of them is, I guess, governance related, and apologies, I could hear you definitely referred to the sort of chairing arrangements for the York Place Health and Care Partnership, and I couldn't tell because of the noise whether you were saying York was quite anomalous in terms of, you know, having Chief Operating Officer as chair. Was that, did I mishear, or?
I think within the ICS, so regionally, all 6 areas have got a local authority place chair, which is really quite unique and beneficial for health and social care to be much more integrated together. So yeah, the place board does have Ian Floyd as the place chair, which I think is a really good opportunity for us, and so as the other 5 areas across the region. They equally have their equivalent, and they will feed back into, with the NHS director, back into what we call the integrated care board, which is chaired by health colleagues and health leads.
Sorry, Sharon, are you going to come in on that?
It's working now. Yes, I just wanted to add really that one of the concerns that we have in York at the moment is that York is the only place across Humber and North Yorkshire ICS that doesn't have an NHS place director. This has been raised as a concern. The local authority has raised it, both through member representation as well as officer representation, and other partners, including one of our local MPs, has raised this concern with the ICS board. It really is caught up in NHS HR processes, but it is proving to be something of an issue for us, as Councillor Runciman will be very aware, because it means that we don't necessarily have the right voice or representation at the ICS board and within that framework. And indeed, Councillor Runciman hasn't received an invitation yet to attend the Integrated Care Partnership either. So it's a bit of a concern. I believe that Stephen Eames, as Chief Exec of the ICS, is listening to those concerns. We've been assured that the post will soon go out to advert, but of course it can take some months before you get someone in place. So I think we have we kind of have developing governance arrangements in place. We're making good progress, and Jamila is leading on some of that work, but we're not quite there yet. And we'll be in a much stronger position, I think, once we have that NHS place director in place, which hopefully will be sooner rather than later.
That's really helpful. Thanks, Sharon. That's kind of, yeah, where my concerns arise from. And I guess that is really, really important, because during the formation stage, you know, the forming and the norming, when things are beginning to take root and the culture is being developed, you know, for York not to have a voice is yeah, quite worrying. But glad to hear that it's being, you know, both member and officer noted and represented, and yeah, okay, that's good. And then may I have another? Thanks, Chair. Just looking at kind of point 16 or paragraph 16, which outlines some of the following key principles. And the point in there around kind of, you know, growing health and care assets. How realistic is that? You know, in an era of kind of managed decline, is it arguably fair to say, looking at kind of real terms, budgets and cost pressures and compounded by inflation. Are we setting off on a false footing in terms of some of these key principles?
I don't think so, because I think not everything is always about the money, because at the moment what we have is health and social care, lots of duplication going on, and some of it, as we've had conversations this week, is building on what always hasn't worked. So a lot of health money goes into things that haven't worked, a lot of social care money goes in. So we build our assets separately on things that don't necessarily work, but we add on to them thinking that they might. I think what we want to do here is, when we say grow our health, it's growing the health and social care assets collectively together. And that doesn't necessarily mean that it's going to be requiring additional monies or additional resources. It's about how we then redesign a different way. So we're not looking at a whole year of re-procurement and going out to the market. It's about redesigning what we have now and what we can do in a much better way. In some areas, like I quoted before, you can have 5 or 6 different teams doing the same thing with slightly different eligibility criteria. You can have social care, so my own provider services delivering something that's very similar that health are doing. But if we bring them together and look at a single, what I call single pathway approaches, you can then really grow the assets that we've got here without looking at putting too much money. Some things may not be cost neutral, some things might, as I call it to my finance colleagues, invest to save. So we invest money into then save in the longer term by reducing the need for crisis intervention, because in York we do have a lot of crisis intervention, high level of dom care, high level of usage of nursing and residential care, and equally hospitalisation. But if we move and change and redesign our services differently down, more of that early intervention, we would prevent that. So I'm not saying everything is going to be cost neutral, but the burden of monies that will be needed is not where we are. And we have the whole raft of data now, which we didn't have before from our public health coverage. So some of the positive things that come out of COVID is being able to have that richness of data where we can identify individuals quite early on to prevent some of that ill health and stop that deterioration. I'm just going to hand over to Sharon.
Yes, I mean, the funding issue is always going to be there. We know that York historically has had, less investment, certainly in public health and NHS services than we know we should get. So that clearly is an ongoing issue for us. But I just wanted to give one very practical example of how we're trying to do this, and that's our workforce. So our workforce is arguably our greatest asset. And at the moment, even though there is very good partnership working happening with our teams on the ground, and we're joining things up strategically, there's a bit of a gap in between that. And one of the conversations we had at the York Place Board on Monday with Charlie Jeffrey, who you'll be aware, from York University, brought a discussion paper about how we can work better as a York system in partnership with schools, colleges, the university, etc., to both attract people into health and social care, look at the content of training, how do we make the training more relevant, how do we have joint training across health, public health and social care, and a real willingness and an appetite to look at doing that differently. And hopefully with the demise of Health Education England and the responsibility for training moving to the Department of Health and Social Care and NHS England, we might actually start to get real progress and be able to make some inroads into how we attract, retain and develop our workforce. So that's, you know, it won't happen overnight, but that's one very practical example, I think, of how we're trying to grow our health and care assets. But, you know, the funding is inevitably going to be an ongoing issue, but that's not just York, that's across the whole of the country, really.
Councillor Runciman.
I think it's working. I wanted to give Stuart an example of Investor Save. I was discussing this with portfolio holders from all around the country yesterday, from Cornwall to Scotland, because what you can't keep doing is trying to throw money at something if you haven't got any money, and you can't throw people at it if you haven't got the right people with the right training. But one of the things I am very keen on, and we are investing in, is assistive technology. Greater use of technology, both by the social workers, say the assessing social workers possibly, and by using it to support people into independence. And we have put money into that, and it is bearing fruit, and it will bear fruit. And for me, that's absolutely right. If something can be done safely with technology, rather than having a person who has to travel to a place and then come back again, and we all know how long that can take, then that's what I would like to see.
Thank you. Any other questions, members? On page 6, paragraph 18, it talks about the enormous potential to find innovative ways of managing and improving care. It's quite a bold statement. It kind of makes me wonder why we weren't doing those things before. So would you be able to give us 2 or 3 examples perhaps of the sort of things that are meant by this and what they're likely to mean on the ground to residents in York?
I think this is where I mentioned earlier about health and social care, investing on things that we already have and them not working. I think most recently, I think one of the examples is through the BCF. We had then consulting that came in and had a look at our whole system, from early intervention to crisis, and what we funded and how we funded that care, and what worked well and what didn't work well. And what they found was that we had lots and lots of services. So we have over 100 services in there that support the different pathways and the key performance indicators within the Better Care Fund. However, they found that we invested really heavily in our early intervention, quite a lot in our crisis, but the whole bit around intermediate care and reablement, which is the most important bit around supporting people with their independence, was not as integrated. And the models were there that work. So you could say, yeah, yes, the systems were there, but we didn't have any different approaches. So we had the traditional model, or we have the traditional model of reablement and the traditional models of intermediate care. Through the work that we're doing now as a single approach, we're looking at bringing in more a locality based on need rather than eligibility. So changing the conversations, and this is where the innovation comes in. We need to change the conversations around, does the person fit a particular eligibility criteria, which happens now, to moving that as what is the need of the individual. And this is where we're looking at bringing in a single system. I'm not talking about Section 75s where you bring teams together. It's the alignment, as Sharon says, of the workforce and how that workforce works well together to say, what is the need of the individual, and moving to localities. So it's going to be a big shift in the way we're working, but equally aligning across the ICSE. So that's just one example that we're bringing in York, and York is the first area of all the 6 that are looking at doing this approach and innovative ways of moving across the system. And as we move forward, I think there was a paper taken to York Place Board around quality and safety, ensuring that our services are of good quality and are safe. Sometimes reduces the need for people going into long-term care by having the right quality of service out in the community. And that is a different approach to saying we need to grow the market. What we're actually saying is we need to have good, highly skilled staff within the dom care market that offer a good quality service. You might then not need the amount of people providing care, but because the care that has been provided is of the right level, you won't have to have then 4 calls a day or 5 calls a day and 15 minutes here and 15 minutes there. It's because you've got the right staff trained to the right service in the first place. So those are just 2 different ways that you can move in over the next 12 months in saying, what does that market look like as we go forward?
Thank you. No further questions, members, on this item? What I'd just like Hannah to suggest, we haven't got any recommendations as such, other than noting the report, and obviously we'll have further updates as the alliance progresses into the York Place Health and Care Partnership Board. But in terms of trying to get that influence for York that you spoke of, and I know Councillor Runciman has spoken of it previously with the Health and Wellbeing Board. Scrutiny officer previously suggested that there might at some point be a meeting cross scrutiny across some of the other areas, including us. And it might be that there might be 1 or 2 representatives from each there. That might be the kind of location that we might be able to obviously try and push and influence as well. I don't know whether you could just make a note, Jane, as to how that's progressing in terms of, I think it was suggested by one of the other areas as a possibility for us to meet across the different localities. And that could be something where members can have a bit of a push for, possibly.
Sorry, Chair, is the suggestion to have that kind of cross geography scrutiny across the ICS and
Yeah,
by the
so
chief
like
exec?
the half a dozen locations. It might be that, you know, I'm guessing you couldn't have the whole committee from each authority area, but you could perhaps have a couple of representatives from each.
Yeah, sounds sensible.
Okay. Councillor Runciman.
The Health and Wellbeing Board chairs meet across the geography, and it's always a useful meeting. So I see absolutely no reason why your suggestion couldn't work. I think it's a very good one.
Thank you. Right, we'll move on to the next one. Sorry, Councillor, please.
Thanks, Chair, and thank you for your presentation, Jamila. Can I ask around just the point that you've raised around how if any thought being gone into sort of North Yorkshire devolution, and if that might impact on these strategy documents, etc.
There's no direct impact on the devolution on the work that we're doing here, because as I mentioned at the very beginning, the whole redesign here is the NHS redesign of NHS services where the local authority are really linking in. So there's no impact on devolution. In terms of delivery as we go forward, there may be some opportunities, but there's no impact as we go forward at the moment.
Item 5, the 2021-22 Finance and Performance Outturn report, pages 11 to 30, and Steve Tate, who's the principal.
Thank you, Chair. My name's Steve Tate. I'm the Finance Manager supporting adult social care and public health. And this is the Outturn report on both finance and performance. So I presume people have read the report, but I'll just give you some of the headline stuff. Clearly, there's a big swing from Q3 to the Outturn position of about 1.8 million. Some of that was hard work, but a lot of that was one-off funding. And that is probably masking some underlying issues that we are going to have to address in this current financial year. What I was also asked to do was to provide some other analysis. So appended at the end of the report is a bit more detail. The budget is cut in a different way. so people can understand what sort of amount of the budget is spent on external care, what comes from grant income and things like that. So I'd welcome any feedback on that presentation. In terms of public health, there's a large transfer to the public health reserve at the end of the year of 483,000. And that was largely due to staff in the public health team being pulled off to do COVID work and that being funded from a different source. There's also vacancies being experienced in the Healthy Child Service. And just in terms of the public health reserve, there is a plan to use that over the next 4 or 5 years that has been agreed by the executive member. Now that wasn't my fault, I can assure you.
We've got
He's
some
here
ghouls in
today,
the
so-
system today.
So in terms of the reserve, there is a planned use of that over the next 4 to 5 years that Councillor Runciman has agreed. Sharon's suggestion. So I'm happy to take any questions on it, and I will be relying on my my two bosses for some of the performance stuff.
Thank you, Steve. Councillor Barnes, please.
Thanks, Chair. Yeah, thanks for the report, Steve. Really helpful. And I don't want to come across as though I'm ignorant of the pressures and some of the reasons for some of the underspends. There's one that jumps out at me a little bit, though, and we've spoken about the importance of invest to save and prevention. And it's obviously the underspend in prevention. A large chunk, if not practically all, appears to be attributed to the Healthy Child Service and the recruitment issue. So was that recruitment issue basically caused by the pandemic and an inability to recruit, or is there something more systemic we should be worried about there?
So the recruitment issue within the Healthy Child Service is different to the recruitment issue in social care, for example, in that health visitors and school nurses who deliver the Healthy Child Service have to do their nurse training first. And they access their nurse training through the NHS, and then they work as nurses within the NHS. They then are required to do a postgraduate degree, a public health nursing degree, and it's a slightly different curriculum dependent on whether you're going to end up as a specialist community public health practitioner or public health nurse for short, for health visiting, which is predominantly 0 to 5, to school nursing, which is predominantly 5 to 19. So the difficulty that we've got really is that there's an acute nursing shortage within the NHS. Not just in York, but in other areas as well. And there's a shortage of health visitors and school nurses in our neighbouring areas as well. So we are competing in a very small pool for those staff. We are doing everything that we can, I think, although we are looking at perhaps some innovative solutions around workforce once it sits with NHS England, but we offer placements for student nurses so that if they get to like York, we're hoping that once they're qualified, they'll be willing to come and work with us. We wholly fund health visiting and school nursing courses, so staff aren't required to put any of their own funding into that. We train health visitors and school nurses, so we offer placements for those as well. And we're as flexible as possible in terms of term time only contracts, part-time, full-time working, job share, etc. And, you know, as a council, we have a pretty good employee offer in terms of flexible working, etc. The other challenge for us is that because our Healthy Child Service is an in-house service, our staff are paid on council pay scales. Whereas the majority of health visitors and school nurses are employed in the NHS. and because fall under agenda for change. And so because NHS staff have received a number of pay increases, there is now a pay differential which is growing between what we pay our council employed staff and what NHS staff get paid. So we're acutely aware of that issue, and are doing some consultation with our existing staff and planning to try and do some engagement work with the wider workforce around, well, how much of an issue is that? Is our council offer an attractive enough offer to encourage staff to come and work with us? So it's complex.
Sounds it, and I really do sympathise. That sounds like lots of big systemic issues which are way out with the gift of the authority to fix. Yeah, I sympathise a lot. So 2 points just to come back on that. One, I'm keen to understand of that 232k what that actually means in numbers of visitors or healthy child staff, and not just net, but what that is as a percentage of workforce, or and then I suppose secondly, this is just more reactive to what you've just said. There is precedent. I can remember well under John Stonehouse of golden hellos and so on, where critical posts were proving difficult to fill, and I wonder whether that's something you've begun to consider.
So I don't off the top of my head know the numbers of full-time equivalent vacancies we've got, although I can get you that information. We're looking at about a 14% vacancy rate across health visiting. We're doing 14%, which doesn't sound a lot, but obviously it puts pressures on other staff. In terms of the flexibilities we might have around, golden hellos and that kind of thing. One of the difficulties we've got is that this service is funded out of public health grant. And members will be very aware that we had 5 years of cuts against the public health grant, and we've had small increases since then, but it doesn't in any way compensate for the money that was taken out of public health services. So it's, if we decide that we're going to invest more in our health visiting and school nurse workforce in the way that you describe, we have to find that money from within the public health budget, the ring-fenced public health budget. And therefore, then there is a knock-on effect to how much money is available for other public health services. I mean, I am looking at that. It's one of the options that we're looking at. But I think if we were going to do that, I would want to be having a discussion with members, perhaps of this committee chair, about, well, what are the implications of that then? I don't want to rob Peter to pay Paul, and we resolve one issue, but then we create another issue over here, and we have to withdraw investment from sexual health services or drugs and alcohol services, or reduce the public health staffing around other areas. So it is complex again, and there are no easy solutions, but I would certainly welcome, Chair, if this is something the committee would be interested in doing, is having further discussions with the committee around that, and perhaps looking at the range of options that we might have with a health impact, perhaps assessment, so that it's not me and Councillor Runciman making those decisions, but we have that kind of broader discussion, and I would certainly welcome that opportunity.
Chair, I would love to do that. I think we as an authority took a decision to bring this service in-house. At the time, I had reservations. Appreciate hindsight's wonderful, and we didn't know obviously that these bigger systemic challenges and the NHS shortage of acuity nurses or urgent care nurses was going to come along. But given that we have taken it in-house, that responsibility sits very much with us, and we talk a lot about early years, about early intervention, about health inequalities. And it really strikes me, this is one of the critical services in terms of best start and all those other things that we always talk about. So I'd love to give Sharon the opportunity to bring it in and kind of talk us through Healthy Child and have a bit of a kind of forensic look at it and what might be possible.
Yes, certainly. I think that's that would be welcome. Thank you. Councillor Heaton.
Got it working that time. Page 19, points 23 and 24, looking at the budgets and the overspend there, it's mentioning that they were overspent because there's been increased number of individuals served. Just in terms of understanding there, were the budgets initially set assuming a continuation of previous numbers, an increase or a decrease? So to explain where we've got to there.
So each year we look at the numbers that are in place around February, March time and reset all the budgets based on those. And we just assume a steady state throughout the year. So we assume that will be the average number for each month throughout the year. There isn't any growth and there hasn't been any growth being built into those numbers for a period of time. We do assume inflation increases. I think in 21-22 is about 3%. That's what we assumed. But what we are finding is, particularly with LD and mental health, the price you pay for the care it's not like older versus residential nursing care, which is quite a homogenous product. When you're paying for learning disabilities and mental health care, they're complex. There's lots of different parts to those packages. The complexity of customers that are coming through is increasing significantly, and that is one of the reasons that our unit price is going up.
Yeah, that's something we found in we looked at children's mental health as well previously. Just a second one, it's on page 21. We've got the number of KPIs there. Now of these, we've got 5 improvements. We've got 3 which are currently stable or neutral. Now, one of those shows safeguarding concerns rising 46% over 4 years. And there's 9 deteriorating. Should we be worried about that?
So one of the things I'm worried about from a financial perspective is the number of residential placements going up compared to the number of home care places going down. That's something I'm concerned about, because that suggests people aren't being looked after in the right place. And we know there's been an issue with home care capacity over the last year or so. And we know there's been an issue with getting people out of hospital into settings and them staying there longer than they perhaps should have done. So that is something that I'm concerned about. And I know the work that Then are doing as part of what Jamila alluded to earlier, looking at that intermediate care pathway, avoiding people going in the first place, getting them out to the right place with the right care and attention to then move them on to the longer term place where they need to be. So that's where I've got some confidence that although it's deteriorating at the minute, will ultimately go in the right direction. I don't know if you want anything to that.
I was going to say, yeah, I think. Yeah, okay. I'm happy for you to.
Sorry, you
Councillor
weren't looking yet. Thank you. I just want to respond to David. I think this is a really difficult question, which I used to ask when I was doing children too. Do we want people to report safeguarding incidents more, or do we not want them to? And it is a debate which I've had before with the stats people. You know, when they say the reports of safeguarding are going up and that's bad, I would like to say if the reports of safeguarding are going up, then it's good, because it means people are reporting it. Now, it might not be that it turns into anything very serious, but we will all know that if you have a soap on the telly, which perhaps is highlighting domestic violence, the reports of domestic violence increase, and so they should. And then qualified and experienced people can look into them and see what lies behind them and if any further action can be taken. So I think you put your finger on a very difficult point, which is certainly one of debate amongst people who put the stats together at the very least.
Thank you. I think that's a fair point.
And the point I was gonna make is looking at the numbers, it always worries us when there's a deterioration, and so it's from my point of view, I have a look at the deterioration and then look at the significance of the deterioration between the last two years. There's not a high significant. I would have expected a bit more coming out of COVID. Now people are having more interaction with services. We can get out and see more services. So Councillor Runciman's point is absolutely well made around safeguarding. We would want to see more of those concerns raised, but equally around the number of people contacting us, and the first point of call being just information and advice. And Steve was saying, some of the customers that are contacting us now, after a couple of years of not being in service, are people who require a bit more than information and advice. And I would say that's that early intervention bit around how can we put those earlier services in that are not just information advice to prevent that crisis. So I would say deterioration is always a concern, but am I worried that there are significant deteriorations here? No. Are there opportunities for improvement? Yes.
Just to follow up, in that case, if we've got positive, at what point do we say we need an urgent intervention here?
I think if you had significant deteriorations, if you went from, let me just pick one, if you went from percentage of adults in contact with secondary mental health and paid employment dipping from, we went from 20 through to 20, and if you had numbers in the 10s and 12s, that means more people were having sustained mental health where they weren't able to support their own employment, and there was over a 50% dip, then I would be really quite concerned about that. You would always see a slight dip in people with mental health not being able to be supported, and as we've seen there, that's something that we need to keep an eye on, but it's not something that we are not aware of. It's those sorts of significant 50% dips or 40% dips that we're really quite concerned, because the recovery would take longer. Here, the recovery will take less, but it's still something that we're not going to say, oh yeah, it's deteriorating, so it's okay. It's about, it's deteriorating, how do we recover quickly from it?
Thank you. Councillor Pearson.
Thank you, Chair. Thanks, Sharon and Jamila. I was wondering about paragraph 32 in the report. Talks about mental health, and guess I'm asking for a bit of a clarification, because it's suggesting that it's positive that more people accessing mental health services in York than the national average are in employment. So I don't know quite how to read that. Is that just saying that perhaps we have higher employment in York, and therefore of those accessing mental health services, it's just statistically more likely that they're working? Or does that say that employers in York are stressing out all their employers more than on the average? Do you see what I mean? I wonder if I might have some clarification on that, if possible.
It's not worded in a very accessible way, is it? And we haven't got a colleague here from the Business Intelligence Hub to be able to explain this. Looking at it, my interpretation of this is that we know that we have high levels of employment in York anyway. And so it's not surprising, therefore, that, you know, the number of service users and secondary, mental health services are a higher number in employment, because that reflects our general population. And therefore, is this actually telling us anything, really? I mean, I'm sure Jamila and I would be happy to go back to Business Intelligence and just ask them in future reports to clarify that, so that it kind of says something meaningful.
So this performance metric actually is not a negative performance metric. So we have people with what we call SMI, it's not a nice term, severe mental illness. And you find in some areas where you have a population of individuals who have severe mental illness who never access paid employment. They do voluntary employment and other things. But in York, what we find is, so it's almost like the opposite, that employers are more likely to support people with severe mental health to remain in paid employment. So we are actually the third best performing local authority across England about keeping people with severe mental illness in paid employment rather than voluntary or any other type of employment, which I think is a good thing. It has dipped slightly, so coming back to Councillor Heaton's question, it has dipped slightly, and we're not happy about that, but I think that was just the challenges that COVID have had in maintaining people in their mental health. So we could reword it, but it is a positive thing.
Thank you. Any further questions, members? Sorry, Councillor Hook.
Thank you, Chair. There was a question about health checks, which was very much to me a GP-led thing. And so I'm thinking that because the GPs are overworked still and understaffed, are they actually going to be going up at all?
So, NHS Health Checks are statutory public health service that local authorities have to either provide or deliver, and they're aimed at residents in any GP practice area. So it's not local authority boundaries, it's looking at GP practice boundaries. Which for us includes some residents who live in North Yorkshire. North Yorkshire GPs deliver health checks for some of your residents. It's just an oddity in the way that it works because it follows NHS geography as opposed to local authority. We were delivering NHS health checks in-house and until very recently. And what we found, our health trainers were delivering them, and what we found was that the people who responded to the invitation to come for a health check and came really valued the service, thought it was a high quality service. But we weren't having the numbers of people attending that we wanted to. And we were having difficulty in targeting those residents that we knew were at particular risk of having either a heart problem or a diabetes problem, any kind of circulatory problem, really. It's GPs who hold that data, not us in the local authority. So we tried various ways of working in partnership with GP practices that they would pull off from their GP practice list who was eligible, and they'd send them a text message and ask them to contact our health trainer service. It's a very convoluted way we had to do it. So we worked really hard with consulting with Health Watch and York CVS did some consultation work for us. We also did a lot of work with GP practices, trying to find a way to make this work. And in the end, we decided that it would be better if GP practices offered this service, that it would make it much easier for people to access, and we would remove some of the barriers that were in place by having it provided by our health trainers. It isn't actually the GP that does the check. GP practices now have quite a wide workforce. So it's likely to be either a health trainer embedded in that GP practice. So one of our health trainers working alongside the GP practice using the GP system might do the health check. It might be a practice nurse. And the other bit of the pathway that is easier is our health trainers were taking the blood test and through point of care testing, but the results had to go back to the GP practice. So the patient pathway was not really ideal. So even though it does seem odd that it's more work for GP practices, actually it's work that they would be doing anyway, and they very much welcomed that partnership approach. And it's working. It's working really well. We're getting very positive feedback from residents who are using the service. GP practices are pleased that it's working. And you know, we're seeing increased numbers coming through. So it's a success story.
Thank you. I've got a couple of questions, and going back to budgets again, page 15, paragraph 20, it references the PNSI supported living scheme being overspent by 635,000. And that's kind of in line with previous years. And I just wonder, is this reflecting more recently further effects of, you know, costs because of COVID, dealing with that, or is there still an underlying issue there and that's not being addressed by the annual budget?
So there is an underlying issue there. There are more customers that are using that service than was previously the case 2 or 3 years ago. One of the things that was supposed to be helping, there was supposed to be a new scheme opening at Wilberforce Trust that was more targeted at a certain customer group. And the idea was we thought we'd be able to solve some of the budget problem in terms of moving those customers to this new setting. I'm not sure that's happened yet. I'll need to check that out. We also think it's probably one of the areas where we benchmark quite poorly against other authorities in terms of what we spend on that area. So I'm not sure we're confident that we've got the support right for those customers that are there at the minute. So if you look at learning disability supported living schemes, we think, and we've probably got some evidence to suggest, that what we're paying for in those schemes is too much what those people need. And so we've made an assumption as when we're setting the budget that crosses across into the physical and sensory impairment customers, but we need to do the work to review those customers to see whether that is a true, what we believe is true or not.
So will that work be done ahead of the next budget then? Otherwise we'll be talking about the same thing potentially next year.
So in terms of the current year's budget, 22-23, that is one of our actions in terms of bringing our budget back in line to look at those customers as a specific piece of work.
Okay, thank you. Page 18, paragraph 35, and it's the survey of adult carers. Just wonder if you can help me understand. So it's telling us that fewer than half essentially think the council are delivering either an extremely or very satisfactory service. Given how important this is to so many vulnerable people, it sounds a little bit concerning. Does it mean that more than half are dissatisfied, or is there a neutral response too that's not kind of referenced here?
I don't know the answer to that. I'll have to go away and talk to our business intelligence colleagues.
Right. Okay.
So sorry, I can't answer that today. Okay,
thank you. And finally, from me then, page 19, paragraph 39. And it's the number of sickness days for employees, really. Obviously appreciate that the figures are likely to be different to trend because of the effects that COVID have had. But from the figures, you'll be able to see obviously who's been off with COVID. What is the underlying, if you remove those sickness days that are COVID effects, has there been a change? Because I'm aware obviously there has been in the past a fairly significant amount spent by the executive on through consultancy to try and reduce sickness absence. I just wonder whether that is now whether we can see an effect of that consultancy work. Obviously, after you take the COVID, putting the COVID element aside, whether we're seeing any improvement there.
I think we what we're seeing in the social care bit of the populations, particularly around COVID, unlike our health colleagues in the very first year of COVID health, our health colleagues had high numbers of sicknesses. What we're seeing now in social care during the last, particularly the last 3 to 4 months, we've had a high number of people off with sickness, and towards the end of last year with COVID related illnesses. We're seeing less people who are off with work related stress, so that the work is compounded to stress. We've seen more people who have been off because they have some illnesses that require a longer term sickness. Some are off because they have operations very similar to the children's report, and then but we still see the higher levels of sickness in adult social care, because we do have a large provider element to adult social care, so it's not just our social work population, and we're seeing that trend now. But what we're equally seeing is that people are off with COVID but are coming back much sooner, and if you look at the percentage of people off long term is very small to the work of the entirety of the workforce population. So it's very variable. We can't really say it's one thing or another, but COVID even now is impacting quite vastly on the workforce.
Okay, thank you. Any further questions, members? No? Okay, thank you. So we'll move on to then it's the work plan, pages 31 to 34. So we're starting to get the diary filled now with items coming forward. The next two meetings, consecutive days in September. So the 27th of September will be the autism strategy specifically, and then the following day, the next main health scrutiny meeting. And we've added an informal scrutiny meeting in. It's to be confirmed yet, but hopefully the 1st of November. Is that confirmed now? Right, okay. So that I would expect will be a meeting, a virtual meeting by Zoom, that 1st of November. Is there anything else members want to raise from the work plan currently? Jamila?
I know it's only a small point, but the autism strategy is going to be a very draft strategy that's going to come. So if we could put draft autism strategy there, that would be really helpful.
Right, okay. That's fine.
So just to pick up that point about a healthy child.
Yeah.
Plan, and sorry, did you say it's already on the forward plan somewhere? I suspect not. No. Okay. So just a reminder that we sort of discussed that, and be good to find some time for it. Maybe ask Sharon when would be a good time.
Would you have any kind of time frame in mind for that, Sharon?
Well, it might be of interest to the 27th of September is a joint committee with children, education and communities, isn't it? So members of that committee might be interested in the Healthy Child Service. So with your permission, Chair, perhaps we could bring a report to that meeting.
Yeah, obviously we'll have to check with the chair of that committee to see if they're happy to have a kind of joint 2 separate items for that.
Yeah.
But yes, I mean, that would make sense, certainly.
And then I had responded to Democratic Services to say that the item on the 28th of September, that local area coordinators would be sit with Jamila, or is it Pauline? Yeah, so local area coordinators and social prescribing actually sits with Pauline Stutchfield, so she would bring that report. And then obviously health trainers would be my report.
Right. Make part of that, Jen, yeah. Okay. The one niggling thing I have is, and I don't know how we broach this, but obviously I think we're all here about the issues with access to GPs, and specifically people trying to make appointments. And we've had discussions before in kind of largely more in the informal meetings, largely. I know it's a national issue, like the dentistry items we've had, but it feels as if, you know, from what we hear on the ground, that it is something that we ought to possibly tackle in actual public meeting setting. I'm guessing, Councillor Runsman, you've discussed it before, health and well-being, and you might be able to assist us in some direction with that, possibly. Sharon.
So the responsibility for commissioning primary care, including GP services, now sits with the Humber and North Yorkshire ICS. So I think it would be a letter to Stephen Eames, who is the Chief Executive of the ICS board. And then it would be up to Stephen to nominate an appropriate representative from the ICS to have that discussion here. Jane, I can pass you his contact details.
Are members content with trying to progress something on with that? Yeah. Okay, thank you, Sharon. Right. Is there anything else members want to raise from the work plan? No, I don't have any other business then. So thank you very much, ladies and gentlemen.